good morning, good afternoon, and good evening, everyone. Welcome to another one of our global cafes. As Berenice mentioned, my name is Roxana, and I'm very excited to be moderating today's session. So social isolation is really one of the most disruptive transformations facing the older adult population, particularly in recent years and since the onset of the COVID-19 pandemic. Therefore, leveraging digital technology to improve the social inclusion of older adults is a very important topic, and one that we have the opportunity to discuss today with two incredible colleagues, Dr. Lars Kayser and Ms. Emilie Wegener, and they are actually here together, adding on to the theme and the feel of the Global Cafe. So thank you very much for joining. Now, as a little bit of background on both our incredible speakers and to familiarize everyone on the call, so Ms. Emilie Wegener holds a master's degree in education science and global health. Emilie has a keen interest in the field of e-learning and health technologies, and she's very motivated by opportunities of new health and learning technologies that can bring within the field of global health, learning, and communication, creating opportunities and access for people in need and helping enhance well-being in everyday life. For more than 3 years, Emilie has worked as a research assistant in translational health research as part of a EU-funded collaborative project called Smart Inclusive Living Environments, so SMILE, the SMILE project, that supports aging in place using digital health solutions. She has experience working with both qualitative and quantitative methods used to identify users' needs and inform design processes. Our second guest, Dr. Lars Kayser, is a medical doctor and board-certified specialist in internal medicine with a particular interest in health informatics and health service innovations. His work builds on an abundance of experience, knowledge, and skills within both medicine, specifically understanding the nature of disease and how they impact individuals, as well as pedagogical and didactic training, participating in a number of research projects focusing on how to transform healthcare services using technology. Currently, these results are very much scaled up in the SMILE project as well, and in the coming years, Lars's research group will continue the work building on their experience with the Epital Care model and instruments to assess users' digital health literacy and technology readiness, together with practitioners and clinicians to inform and facilitate successful transitions and transformations of digitally enabled healthcare services. So we really could not ask for two better guests to discuss this topic with us. Thank you very much for joining. And I just want to actually hand the floor over to you both to discuss a little about your experiences with, of course, your extensive experience in research and health technologies. Can you further elaborate on your professional and personal journey? So both of those leading you where you are now, as well as some of your work around technology, please.
Would you start? Yes, I can start. So as you mentioned in your very nice intro, my journey within this research field actually already started during my master's thesis in education science, where I saw what technologies could actually do to promote learning and to promote education across countries. And so when I entered my master's in global health, I knew that I wanted to pursue the e-health track. And that's where I met Lars, which really introduced me to the field of e-health and to what different projects are exist out there already. And so in the SMILE project, my experience have been to be very much in the field, and I've been doing a lot of the field studies together with my great colleagues at SMILE. With our target population, which is older adults. So I've been around like that. Yeah, maybe you can.
Yeah, And I'm a little bit older than Emilie, as you can see. I'm actually 65 years. So I'm now in the group of older adults. So I'm going to use a lot of the things we are inventing, I presume. My journey started as a medical student in '81 in Baltimore, where I saw how computers could be used in the care of trauma center patients. And then during the years, I have experienced different kinds of technology, and in particular, how the smartphones were introduced in the zeros and how they could help people. At the same time, for more than 20 years, I have been legal blind or have a decrease in vision, which means I have been a user of assistive technologies and have a huge interest in how it can help people and influence people in their everyday living. So I'm both a user and a coming more user. And then at the same time, I also need to understand it from the researcher perspective, from an objective. So I try to combine this subjective and objective way to understand what is going on. And I have a huge curiosity that I hope we can come back to in what will happen in the next 5-10 years. But first, I think we now should talk about our current work. But thank you for your very nice introduction, Roxanne.
No, thank you both very much for joining. And with both your work focusing on how to transform healthcare services using technology, can you just spend some time sharing with us some insights about really the role of technology, specifically in the social well-being of older persons, and also how the use of digital technologies can lead to reduce social isolation as well?
You start, or?
Maybe you can start and then I can tap in with my, my thoughts.
As we're talking from two positions right now, we are divided between us today, as Emilie has done a lot of field work here, both in Denmark and Norway, and some in Canada and Netherlands. And I have not participated in the specific field studies, but I have a huge experience from many different research projects we're involved in, and also from data. And when we're talking today, we are both talking directly from SMILE, evidence SMILE data, the project we are presented with here today, but also what our research group has been doing. And you ask about this, about how can we avoid older people, older adults, social isolation, then it's very much about the technology by itself is not the solution as it is right now. Technology is more a mediator or a means to communicate. And what we can see is that people, and all you here will probably know that people that are socially isolated, people that live alone, they have a higher risk of becoming more ill. And when they're ill, they have a more severe course. And it's shown in a lot of studies. We actually have a very recent study, not published yet, here in Denmark, that shows that a general population, again, people that live alone, have a lower level of health literacy, lower level of digital health literacy. And interestingly enough, in contrast to studies from e.g. China, it does not depend on who is the person they live together with. I'm familiar with studies in outside our group, one from China and also others that shows that it's the importance of the spouse. But what we can see in our study is that it's actually not what kind of role the other person has, but it's a matter of whether you are alone in your situation, or you have a partner, spouse, child, grandchildren, whatever, or a roomie. It's more about to have someone to communicate with. So the important thing here is to avoid that people live alone. And that's where technology can help. And we will come back to that also. How will it influence if you have cognitive impairment at the same time? But I think you have experienced some interest from older people in your design workshops about their interest. What kind of interest did they have in using these technologies?
Yeah, so I think there's especially two perspectives that came to my mind in this question, and I think I will come back to some of the other specific parts of the field study when we move along. But for this, I feel that, or we saw that a lot of the participants in SMILE sometimes were not really aware of their own capabilities. So if they are actually introduced to some technology that can help them gain a better understanding of their health and their condition on each specific day, each specific hour of the day, they will actually be able to be more social, do more activities outside their homes. Sometimes the isolation is due to their condition that they're simply not aware of what their capabilities are. And the other aspect that we saw that were both asked for and that the technologies could maybe bring to the table is that it can provide them with an overview of what activities are actually in the area, just to be inspired to know what is out there actually. So I think that's two important aspects of this, what the technology can do.
So
Thank you.
increase self-efficacy and at the same time also provide a palette of services.
Yes. Two important things. So, and I mean that because some of these participants did live alone and they did want to go out and a lot of them had opportunities and people to do that with, go for a walk. But some of them, we were talking to people with COPD especially, and for them a big concern was, well, I don't know how far I can walk. I don't know if I will make it back. I don't know if I will have enough air left simply on my walk. So technology would possibly be able to help with that concern.
No, thank you both very much for that. And I really like what was said of technology is not the solution, it's a mediator. It can help a lot. Now, shifting gears to learn a little about the project, the SMILE project. Can you share with us what SMILE project is, the Smart Inclusive Living Environments, and how the collaborative project really supports aging in place using digital health solutions?
Again, I think you should start because you did the application.
Yeah, it is a collaborative project between Norway, Denmark, the Netherlands, and Canada. And we have different focuses. One focus is that we already have had a setup in Denmark around the epital care model. Maybe we'll come back to, but we had a certain setup in a living lab, and we wanted to show how this could be translated and transferred into another setting in Norway, and we have been successful with that. And then we also wanted to see how it could be translated or transferred from a focus of COPD and cardiac disease into dementia, cognitive impairment in the Netherlands, and post-surgical patients in Canada. So it's very much about translatability, and how to not only use a technology and a telehealth center, but also design it as a smart living environment from a socio-technical perspective. And that means that we have invited small and middle-sized enterprises to join the project, like a store. You know, we have these different kinds of app stores from different vendors. And here we have created a carousel, it's called, where we have a connectivity or a kind of website where it's already now, I think it's 30 small and middle-sized enterprises that have joined us in order to be able to provide new technologies into our system. And then at the same time, we have had the design process to design a conversation agent. It's more like a structured bot. It's not like the advanced AI that has developed here over the last years. And it's important for us that it is structured dialogue, so we actually can know what is the information is about, and we can design and tailor it to the different areas and different needs. And the overall thing here in the SMILE project is that we, as clinicians, researchers, 4 different living labs with different perspectives, different levels of maturity in the development into a social technical system, and with different commercial partners, actually have been able to work together here now for 3 years and have come with some preliminary results.
Yeah. Okay. Did you also? Yeah.
No, that's wonderful. Thank you. And have there been any specific key findings that you would really like to kind of further elaborate on the project, and even just some barriers perhaps while doing the or some barriers that you weren't expecting to experience?
Yeah.
There's a lot of barriers we will come back, but I think if
Yeah.
you could present how we came to the three principal functionalities.
Yeah, I can tell the key findings from the co-creation part and the development of the conversational agent, which is the technology that we have developed in co-creation with the participants. So basically, the overall I don't know if I should just say the key findings now, probably. So we found 3 features that was the most important to the participants, and it was a My Health function, a function that could give them an overview over sleep and inspire to enhance sleep quality, and then a function called daily activity, which was actually a combination of social activities and physical activities. So that was the 4 main important findings from the co-creation workshops. And we found that the participants were open. They were open to use technologies in their everyday life, both to monitor their health and to do these social activities. There was a lot of emphasis on the social part. But then we also found that a lot of the participants had a real concern that the technologies were gonna come and 100% substitute their already established conversations and consultations with the healthcare sector. So they were not open to that being a substitute, but it being an add-on or something that could complement the existing in-person dialogue. Yeah.
And that has then been implemented in our SmileBot, that is the product. And it's also important to say it's not Emilie and I that has done all this. We have these partners in Norway, Canada, and Netherlands that have joined us and made the ethnographic studies, interviews, and in particular Sintef in Norway have developed the SmileBot part, and other Tendertænder Pinux in Denmark and Greece/UK have developed a dashboard. And that's also another finding, is that for the people with cognitive impairment, we have not been able to identify something that could be incorporated into the SmileBot or being meaningful for them, as people with severe dementia, moderate dementia, are a little reluctant sometimes to use technology, and it's more difficult. And most of the pressure actually is on their relatives taking care. So we also found out and decided, by input from the Netherlands and confirmed in a Danish study, that it should be designed for the relatives. So another product is a dashboard. So it's not only the SmileBot or the bot for the patients, but also a dashboard for the caregivers, that informal caregivers, relatives. So some of the pressure can be relieved from them. So that's also an important finding, or maybe a confirmation of what is already published, but here addressed as 2 different products.
Thank you. Thank you very much. And Emilie, in the beginning, you touched on this aspect of field work, and I just want to unfold that a little. With the enablers of the UN Decade of Healthy Aging, voice and meaningful engagement of older adults is very much a critical part of it. And also it's very much included in the SMILE project. Can you share with us how this project integrates voice and meaningful engagement, and particularly its relevance within the field work?
Yeah, so I can try to give like an overview of the entire methodology behind and our thoughts. So basically we did around 14 co-creation workshops across the 4 sites. I took part in the ones in Denmark together with my colleague here, and our colleagues from Norway also came to join, and then we went to Canada, made workshops there, and also Norway, and then there were some workshops in Netherlands as well. So all the way around 14 and around 55 participants on all sides. And so the process was this iterative co-design process. So we had 3 phases of workshops, where the first phases was to identify what is the needs and preferences from these participants. And we had formulated 9 different features that could possibly be integrated in this final technology that we presented to the participants and had a lot of good discussions with during the first phase of workshops. All the workshops were built on open-ended questions and had a mix of different single tasks and reflection tasks and group work, just to get all around input and also to create this safe environment where the participant could actually share their thoughts and their honest opinion about the work that we were doing. And it's a very humbling experience because they felt very safe. So it was nice. They were very honest. And so after the first phase of workshops, we did summary reports, and we obviously had an ongoing conversation with our developing partners in Norway and in Denmark. We also had in Greece. And so for the second phase of workshops, we had already developed this prototype that was then presented to the participants. So they kind of like, their voice was a part of the entire process of the design process. And that was what was really the intention. So at the third phase of workshops, they were presented to the final prototype, or the first prototype. The second phase was a mock-up, sorry, where they could try it out and provide their input to that. So the purpose was really to make sure that they were a part of the entire process, and that their opinion, that they could see that their input actually helped change and evolve the technology. Yeah.
Yeah, and maybe I can be a little provocative here, as I know it's very important as a culture in many countries now to include advisory boards with patients, advocacy groups, etc., etc. And what we did here was we did not include the national associations for lung disease or heart disease. They have been included at the living lab that we worked, so they had been there in the background, but not for this project. And the reason for doing this is that we instead administrated the READY instrument, which is a survey to assess readiness for health technology, looking into self-management, social connections, and digital health literacy. And based on the answers on that, we clustered into 4 profiles, and then we recruited the participants from these 4 profiles. So we ensured that we would have the voice of people that is normally not participating in boards, and normally not those being in the different patient associations. Not to say they are not important, and in other connections I'm very much aware of them, also have contact to them. But the design idea here was actually to get the voice from the floor in a bottom-up process. And another thing is important is that there was conducted a scoping review. Emilie wrote together with colleagues from all 4 countries, where it was also identified that it's important that people are involved in all phases, and we have really tried to ensure from the idea generation to the design to get feedback from the patients in all steps, so you can look into that scoping review. And also one of the articles I'm still very fond of, you identified, that was Lindsay from 2012, that actually writes that people can have an impairment or disability. And the matter of whether you have an impairment or disability is whether, if you have impairment and introduce the wrong technology, then you are disabled. If you are disabled and get the right technology, then you're only impaired.
All right, well, a lot of things to unpack in that, but before I do, I'm also very cognizant that there's a lot of questions and comments in the chat. So I will address some of those first. We have a comment by Mr. Shmuel Yerushalmi, a question actually, and he is a weekly contributor to our global cafes, and his is specifically around the use of AI. So whether either of you have any opinions and ideas regarding the opportunities to improve social inclusion of older adults, specifically with artificial intelligence-based technology.
Yeah, I mean, I can just start by saying that we had a lot of discussions around AI in relation to Smile, and that one of the reasons we ended up doing these conversation-based trees was to kind of keep the conversation within the specific information that had to be given, so it didn't kind of provide wrong information to our participants. But maybe
and it's, thank you for the question. It's very, very important. It could be a very long answer. But actually we planned to use AI to a certain extent. AI can be defined in many ways and understood in many ways. And actually some call our cluster procedure using K-mean a kind of AI. But I think that the question more means things like generative AI, and in particular what we see from some companies with large learning modules, etc. And we had, as Emilie said, this discussion. The problem right now is that if you should use material, then you need to have the open AI or whatever bot system, it could also be others, to gather the data from a specific area to ensure that it's not wrongful answers it will provide. And I know that can be done, but it turned up here within the last 2 years of our project. And what we have seen until now, also making small tests ourselves, is that we still need to have this structured material, and it would take some more time. But if the question is, can we see it in the future? Yes. And maybe you should come back to it later, but what we can see is that systems where you can identify certain kind of resources that is very large and complex, then we can have a generative AI module be working like the co-pilot that you already see from Microsoft in their English products. You can have this co-pilot for the elder people, theoretically. I know it's only on the chat answer, so I would prefer to come back to that later if we have time. But it could be used, and we're looking into how it should be used, but we really right now to be very careful about what kind of material do we select for this generative AI in the LLM modules that will be offered, e.g. in the OpenAI store, which has just opened. So there will be a lot of solutions there, but the use of the ChatGPT as it is today, 3.5 is too unsecure. If it's that isn't the question, but else AI is a lot of things. It's in our phones, our cameras, everywhere. So of course we use it and we will use it. But with respect to the generative AI, there's a potential, but we have to do it slowly.
No, absolutely. And then there's also the whole other realm, like the realm of the ethical use of AI. Now, I see in the chat, Dr. Anjali Tripathi, you posed a question. Anjali, would you like to unmute to pose your question to our speakers today?
Thank you, Roxana. Greeting Dr. Kayser and Ms. Wegener. I am Anjali Tripathi, Secretary General of IFA. I have a question. How can we leverage digital technology to older people of different socioeconomic strata?
I think Lars has a really good answer to that. Yes, because the ready instrument.
Yeah, that's a little what we talked about. It is if we're going to target different people in different cultural settings, different places in the world with different maturity of technologies and different availabilities to technology, there's two things that are important. One is that we can make a map of the groups in the population or the group that we are trying to address. And here we are very much inspired by Professor Osborne, which is a colleague and collaborator that has inspired me and us a lot and been also a mentor for me. He has developed the Ophelia process, where the idea is when you have clustered people based on certain capabilities or characteristics, social demographic characteristics and capabilities, skills, knowledge, then you can identify particular areas from different groups as you need to address and divide into different groups. And you can also do that in large scales if you need to understand. That's one thing. The other thing that we have recently written about in the European Respiratory Society's latest monography is that when we as health professionals or social care workers or organizations meet people, we need in our conversations with them introduce digital media if it's appropriate, electronic healthcare records, social care records, other resources, ask them which kind of resources do they use, have a conversation about, is it sound information or is it maybe not valid information? Why do we think as health professionals it's not? So we have it as a part of our meeting with people in the different contexts to align and understand. There's a Danish philosopher lived 200 years ago, 150. I said we need to meet people where they are and understand what they understand. And we have these kind of instruments to try to do it, and then we should do it in our conversations and in our planning of where and how we meet the individuals. And in that way, we can introduce different technologies, and that's important, in particular for people that begins to be cognitively impaired, to introduce technologies that are familiar. Watches, which is more like watches, and then have some of the capabilities, then they can maybe be more advanced. As TVs that are intelligent, so they can also support other things. When we communicate with our Amazon, Google Hub, HomePods, whatever, our different smart hubs, that is in a setting where it's familiar to people. And I know we have a very wide audience, so some of my answers also based on coming from a country with many resources and many digital persons, but we certainly also have persons here not being digital, not having the resources. So you should just consider my answer into the setting East Africa, where you have the normal, the old phones, where you have the SMS. You can do a lot of SMS conversations, how to introduce that, how to have people in front of you understand advices around pregnancy or chronic condition, malaria, etc., tuberculosis. Then you should have this dialogue and where do it come from? So we should meet people where they are.
Thank you, Dr. Kayser and Ms. Wegener.
No, and thank you very much, Anjali, and our incredible speakers for that. I see, Dr. Asha, you also posed a question in the chat around the use of technology in the context and in instances where there's nonverbal communication. Dr. Asha, would you like to unmute to pose that question to our speakers today?
You have already read my question, so I would request doctor to answer, because technology is, what will you call it, dry. It will make elders more isolated and lonely if they are dependent on technology only. So when they are in person talking to each other, they have non-verbal cues also, which makes them understand, feel. How will AI, it will be like, our mobiles are flooded with messages which do not concern, and now we don't even look at them. Won't it be like that again? Dryness, isolation, loneliness will increase because of technology's excess use.
So
yeah, I can only agree on that, but it's important to say that the nonverbal communication is often considered as very important, and I'm talking of as a clinician. And you're very often talking about these screen consultations, video consultations. But in our experience here in different projects where we have designed it based on video consultations, 95% of all contacts is by phone. without any kind of nonverbal communication, and the participants, older people with different chronic conditions, are quite satisfied about that, as it's easier for them to call when they need and just take the phone and ask, instead of most elder people, and particularly women, would like to be a little tidy, would like to sit in a nice place, and it must not be rubbish behind them. So they have to prepare for the video. And then if they have some breathlessness problems in the COPD, it's much easier just to have the phone and not think about themselves. But certainly it's very important. And when you come to this trust or safety space in your conversation, it will often, we have seen it in pre-care, we have seen it in SMILE, we have seen it in other contexts. It's very important to have this physical initial meeting. So we should never have only virtual. We have actually recently published a small study about what do people prefer in rehabilitation, and they prefer a combination of in-person and virtual services. So I fully agree about the nonverbal communication are sometimes important, but when you have bonded or created the rapport, a word I learned the other day, not report, but rapport, you can then have this kind of conversations, and then you maybe not miss the nonverbal. When I heard about the nonverbal, another perspective, I know some, maybe one is here today, is people that are mute or deaf. As they need to have one kind to actively interact with others, and help. It is possible today with the different systems, operative systems. We have the different computers and smartphones. So areas of the world where we have computers and smartphones, we can actually do the nonverbal communication through simple media. And then I know there's some broadband and there's some accessibility. But for many people, and in particular the high-income countries, it's a larger part of the population that will have this opportunity.
Well, thank you. And thank you very much, Dr. Asha, for your question. Dave, so I see the next question in the chat is from Mr. David Richardson around the digital gap. David, would you like to unmute to kind of pose your question to our expert speakers today?
Sure. I'm concerned sort of in a practical way at the fact that we're talking about the advancement of technology, and we're talking about the older adult population. And we know that in most communities, roughly 30% of older adults are not comfortable with the use of computers. And we also, at the same time in Canada, and I'm sure around the world, governments and the private sector are digitizing more and more service delivery for reasons of convenience and so on. And so there seems to be a widening gap with no one stepping in at a corporate or government level to develop and design programs specifically to assist those people who are not as literate as they could be with respect to computers. And it seems to me that could be creating a bigger problem than it's solving. So I wonder whether you see an obligation on the part of governments, but and also the technology industry to specifically try to reduce that gap and reduce the number of older adults who are not computer savvy.
Yeah, I fully agree with you. I have two answers. A very short answer is that your numbers are also confirmed here in Denmark, approximately the same. On the other hand, when we in telehealth introduce and onboard the way I have mentioned here, then it's almost all which are not moderate cognitive impaired that we are actually able to include if we can provide them with the resources. So it's maybe not necessarily a huge problem, as you say here, when we have this direct interaction in a clinical setting. But I fully agree with you. And in Europe, we have an EU regulative that says that all public systems should have accessibility and be designed in ways where it's accessible for different populations. So there is an attention to that. And we are also, already in 2014, the EU published a paper about digital health research working in the field. In Denmark, we have a Minister of Equity, which includes digitalization, and we also have a board under this ministry working very much in how to include different cultures, but also how to have the digital inclusion. But it's not just bright light. There's a lot missing. There's really a lot missing, but it is recognized at the higher level in Europe and in Denmark and many other countries. And we have conflict of interest declaration here. We have a instrument E of literacy questionnaire, which was developed together with Professor Richard Osborne, where you actually are able to describe populations. And one region in Denmark, we have 5 regions. One region have done it, and another region have included in every third year national health profile. So there is an interest at the organizational level in how can we characterize, how can we understand where are the problems? Is it in the motivation? Is it access? How to interact with information? Is it that you do not understand the concept of health literacy? Is it the computers, or is it that you do not feel safe? So there's a lot to do here, and it is, yes, thank you for the question. It's a very early stage, and there's a lot to do, and I fully agree with you.
And just to add just one perspective, just because we're also kind of venturing into a new project now, being aware of the different layers, right? So we need to focus obviously on the people who are the service users of the technology, but also maybe be aware of the people who are providing this technology to the people. What tools can they use to better understand the patients or the people they are providing technologies to, and what can help them kind of make their work easier.
Yeah. There's actually a study from a few years ago from Australia by Cook. We have done 2 small studies after that, and all 3 studies we see about 15 to 20% of the healthcare professionals have a kind of anxiety or feeling of not being complete, or have the full competence or feel the full role when technology is part of the interaction with the patients. So it's also a challenge for the health professionals that we all should be aware about.
Thank you.
No, and thank you all very much. And I guess dovetailing off of that, and just to further elaborate on what you were speaking on, Lars, how can we just continue leveraging the benefits and the value of technology to kind of overcome this barrier and the gap in some of the accesses that older adults may face with technology?
Yes. Yeah, that could be 3 or 4 hours. But very short, it's actually to recapture a little of what has already been said. It's very important that we have the organizations, depending on which country and structure, regions, whatever, behind us. And if we have a public health system, then those payers there. If we have an insurance-based system, then those. And then in these situations, actually to understand what are the particular needs. All knows it. One size does not fit all, and we really need to address the particular needs. And then a very important word is to do it where it's meaningful. And we can see, as I mentioned, that people with some cognitive impairments, older adults not being that experienced with technology yet, they really need to have it introduced a way where it does something for them that is meaningful. It should shoot a problem. It should not be us introducing the problem as something we think is a solution, as then we will create the problem. But we work very much from the Stanford Inspired process and many others, inventors, as identify the problem, introduce the technology in the context of it, do it in a meaningful way where you create this sense of meaningfulness, that it has an impact, ensure the self-efficacy, and also try to create a motivation around it. And Emilie and I, we discussed before this session here that we would like to introduce a good Danish Scandinavian word to all of your participants here, which is called tryg, T-R-Y-G. It's a Scandinavian word that means safe and comfortable. And trust, and it's also have kind of coziness. It means when you come with something, if you have this feeling of being trygness, then it means that you are convinced and feel that is good for me. So that's actually what we call in Scandinavia. That's important to create this sense when we introduce it. And the way we can do it is by a collaborative effort where the industry, our people in the healthcare sector, and those in the organizations behind actually will put in the effort to meet for each kind of disease, each kind of intervention, where is the different technologies meaningful, and then set it up in this way, and then use the time to onboard people. We have seen in a Danish study with telehealth for COPD, we spent 2 hours together with the patients initially, 2 hours to onboard them. But after a short time, they do not use the service very much. They do not call in the evening or night, even though it's 24/7. And we have done it 3 times now in 3 different settings, and it's the same result each time. If we really introduce the right way, they will buy in, they will find it useful, and they will use it, the sum of resources less.
And I just have to add another way to kind of practically overcome this barrier can also be found in the scoping review that you mentioned earlier that me and some colleagues conducted, where we found these like 3 main gaps, where you mentioned one of them, that we're not including all the participants who are in the frail or impaired group, or the ones who are maybe most in need of new technology. So people with cognitive impairments especially were not included in a lot of these studies that were about doing co-design technologies. And then another thing was that the participants were not included in all parts of the process. They were mostly just a part of the last part, where they had to provide feedback to a technology that was already designed. And then the third thing was that the recruitment strategy for these involvement processes is very important, because as you also mentioned earlier, that there was a bias. Very active participants were recruited, not a broad variety of different people.
The usual suspects.
The usual suspects.
No, thank you very much for that answer. I heard a lot of person-centered approaches, and having that collaborative approach is really important to address some of these barriers. And I learned a new word. Turk is the pronunciation.
Yeah.
Will be added in my vocabulary. Now, I know it's Nancy Hoden. You have a question as well. So Nancy, would you like to unmute and pose your question?
Good morning, and thank you. Very, very interesting conversation. And the work that you're doing is so important because it is collaborative, that you are using people who will use the products eventually to develop them. And I'm wondering if there's a trickle-down impact from your research. You know, there are people out there in the world developing technology who don't have your insights because of your research, and they could be so well served by incorporating what you've learned from your subjects and your patients in the development of their own technology. So what comes to market eventually serves people in the best way possible. Are there organizations, you know, in Europe where you are that are helping people, technology developers, to learn more about what you're doing so that they can incorporate that in their own design?
In Denmark, we have an initiative called Danish Life Science Cluster, where a huge funds shifts to fund this. It has just been the Novo Foundation, and now it's the Lundbeck Foundation, which is 2 big medical foundations. It's not the companies, but it's the foundations. And here, patient organizations, companies, and researchers, clinicians are applying together. And I also know there are a lot of European grants where it's a demand, like the SMILE, that we go together. And then we try to be part of different events like today, and in the Active AL.
Aging Fit.
Aging Fit in Lille in March, and we are also going to other places. So we really want to share our data, and also in a Danish perspective, we are publishing in more untraditional papers that is read by other people, including industry. But if you know about other spaces where we could share our knowledge and work together with industry, I would be happy to learn about it in other regions. But we really try to do it in our context and also in our project here.
Yeah.
It's so important. And I can say, sorry, I can say our Canadian partner is McMaster, that works together with a company, cordially, where they do all the development together. So they actually have this tandem-like work where they directly input and test. And we have this same set. I know a lot of different settings like this around the world, actually. But if you are asking my indirectly, could we do it better? Yes, and I would really like to learn good examples, good practices around that.
What I'd like to help is to get those, to do what you're saying, is to get more people aware of this. And we work, the Global Coalition on Aging works with the World Summit on the Information Society, and we put together every year a Healthy Aging Innovation Prize. And this year, it hasn't launched yet, but we're launching a prize which will focus on how technology can impact social isolation. So we're encouraging developers of this technology to come out and to share with us their new developments, their new technology, and hopefully give them more awareness in the world. So I'd love to connect with you afterwards to tell you more about it.
Thank you. Very important.
Thank you very much, Nancy. And we are slowly coming close to the hour, but I also just want to acknowledge all the incredible comments that were posted in the chat. We have multiple by Miss Anna Maria. We have a lot from Brendan Sherlock, Francis Wilkinson, as well as Mark Manning and Eileen from Ireland. So just thank you everyone for posting all your comments in the chat. But before we go to our key takeaways from you both, I also just want to get your thoughts, Lars and Emilie, on how you envision the use of technology progressing in the next 5 to 10 years. I know it's a big question because there's a lot of ways, but
yeah. So I think for my future vision, I hope that this movement towards more co-creational technology design will keep on going, which means that in the future, we will not have as many unused technologies or technologies that are enhancing stigmatization, technologies that will actually enable this increase in social isolation and more self-efficacy. So I'm going to keep on going in the co-creational area.
Yeah. And we have discussed it a little bit the days before the preparation here.
Yeah.
One thing we discussed is in the co-creation processes, will we in the future see the AI entities being part of the co-creation? Will they be the co-creators? And will we as individuals, older adults that are isolated or at risk of becoming isolated, will we have these friends or bodies floating around in our rooms in a kind of materialization or entity or as AI, like Star Trek? Maybe, maybe not. But what we can see in the current thinking is that people often will only take technology to them if it's meaningful, if it makes sense. And if it's to avoid social isolation, it's much more about facilitating access, as Emilie mentioned already, to different things and being used as a means where you can have a conversation together with your relatives, your informal caregivers, your bodies at the different sites. But if you're a person that is alone from different social demographic things, then we need to identify them, we need to introduce it to them before they can take advantage. The technology will just not flow into the room and be meaningful. But what I see right now is that we'll have a change from these terrible dialogues we have with Google Assistants and Amazons, where we almost have to explain them what we are saying, into technologies that much better understand us, so there will happen something. But one reflective position is also that the youngest Generation C, is actually moving away from technologies and social media. They want to be much more physical. And we also have trends in Denmark where older adults and care centers actually is built together with kindergartens in order to facilitate a physical connection. So you have this connection across generations. And here I see technology to be something that you can use together and maybe be something you play with, but the technology in itself may not necessarily be the solution for the oldest, unless they have a disease, but then it's not the instrument to avoid the social inclusion. And I'm not sure that we'll ever get there where any generation of older adults will think that the technology should be the solution, but it should rather be a means to get contact with others and maybe have this bridging of generations.
Yeah, well, thank you very much. Actually, Chris Kobus in the chat said technology enabler, not the end solution. And you very much thank you for stressing this. Now, I'm gonna give you both a few moments to just gather your thoughts on some very brief key takeaways to share with us all on today's session. But before doing so, Berenice, can you please share the screen for our next week's session? Thank you. So next week, we have the opportunity to listen to Ms. Stephanie DeChassi on the topic of voice and meaningful engagement as part of multi-generational approaches. Ms. Kira Cruz will be moderating that discussion, and it will be a phenomenal Global Cafe. So please do join us, and we look forward to seeing you then. So back to you, Lars and Emilie. What are perhaps one or two key takeaways from today's session that you'd like to end the cafe off with?
Lars will start.
I'll start. Yeah, one is consider the word tryg.
Yeah.
And the other message is meet people where they are, understand what they understand. You should facilitate, you should serve them, and have the technology to serve the purpose and not be the solution, as it will then often create the problem. And then we have to do it in a sound way where we actually understand how to introduce each one to the meaning of the thing we want to involve them with.
Okay.
Yeah.
Well,
Technology as a social enabler, not a
Yeah.
yeah.
thank you very much. Thank you both very much for your time, your expertise, and your insights. And as always, thank you every single person who joins these cafes. You make them as amazing as they always are and as interactive as they are. So a big thank you on my end. And also extending a thank you to the IFA team too, who helps run this cafe and every other cafe as well, particularly Berenice. So thank you, Berenice. Wishing everyone a great weekend and a happy Friday, and hope to see everyone next week. Thank you.